Hello, and welcome to my diagnostic ultrasound video specifically for MCL. A quick anatomy review. As you can see, the MCL begins on that medial condyle of the femur. It runs its way down past the joint line and then inserts on that medial aspect of the tibia. So now getting into the actual procedure itself, we'll begin with the patient position. First, we will have our patient supine. We'll have their knee slightly flexed to that 20 to 30 degrees. This will help put slack onto the quadriceps. Ideally, we want to put some type of cushion under the knee, whether it be some type of bolster or even a foam roller. And then we want also a slight external rotation of the tibia to expose that medial aspect of the knee. In the next slide, we'll take a look at a picture and explain it further. Transducer position. As you can see from the picture, many of the things that we looked at on the previous slide are being shown. The patient has slight knee bend. They have external rotation of the tibia, which helps expose that medial aspect of the knee, and a bolster has been placed underneath the knee. If you look at the transducer, you will see that it's being placed on the joint line of the knee and in the longitudinal view. This will give the best view of the MCL, especially when working superior to inferior to see both insertion and origin. Video of the ultrasound procedure. There are two videos here shown, one showing what it looks like to do from a clinician standpoint, and the other is what you'll see on the actual ultrasound. In both of these, it's most important to find your starting position. I would highly recommend to find the joint line. When you found the joint line, place ultrasound gel on there, and then place the ultrasound there. This will help you find the reflective bones of both the femur and the tibia, and you know that once you've found those, you can begin to examine the MCL. In the next slides, we can discuss the anatomy of what it looks like on ultrasound and also when there's pathologies. Now this is a still picture of the scan. As you can see, as we discussed on the previous slide, the reflective femur and tibia can be seen. The joint space is very distinct, and within that joint space, you can see that MM label, which means medial meniscus. Right above or superior to that, you start seeing hyperechoic with mixtures of hypoechoic tissue. This is the MCL working from superior to inferior along the joint line. When we talk about moving superior to inferior with the transducer head, this is very helpful in distinguishing what this tissue looks like, especially if you're looking for pathologies. On this slide, we'll discuss a pathology that can be seen on the scan to the MCL. When looking at the white line, we will start to see some difference in the tissue. The continuity begins to fade there underneath that arrow. We start to see more hypoechoic non-signaling. This shows a disruption to the MCL fibers, indicating a possible sprain. Looking more inferior to that white arrow, we will see a larger hypoechoic buildup, and this is consistent with fluid buildup and hematoma. This is more seen in the deep fibers of the MCL, in this case of this image. As we discussed before, it is important to make sure that we toggle so that we can differentiate and don't mistake anisotropy. Here's another example of a pathology. With this one, we can see the clear indication of hypoechoic breakup within the MCL tissue. If we begin to look at the top, where the arrow points right at the tip, we can begin to run all the way down that line and see a jagged type hypoechoic signaling. This runs almost all the way down into the medial meniscus joint line aspect. This is a hypoechoic interruption, which represents a possible tear to the MCL. Supporting literature. While conducting a review to find supporting articles, I found an article named Point-of-Care Ultrasonography for Diagnosis of MCL Tears in Acute Knee Trauma. This was conducted in the emergency department with patients who were suspected of having MCL tears. The methods were that a history and physical examination were completed, along with a radiograph. If imaging showed no fracture, point-of-care ultrasound was completed. Within a 7-day follow-up, MRI was completed. Then also a second point-of-care ultrasound was done. The findings of the point-of-care ultrasound and MRI were compared in diagnosing MCL injury. On this slide, we will discuss the data that was extrapolated from the article, specifically the positive and negative likelihood ratios. As you can see from the red box highlighted, the negative likelihood ratio for the first and second ultrasound differ a little bit, but both land within the moderate range. If you look at the positive likelihood ratio, we see that both of these numbers are above the 10 threshold that we like to meet. From this, we can say with confidence that point-of-care ultrasound is good at ruling in and moderate at ruling out.